Hi guys, it's Dr. Sloan. Here I'm going to do a little demo for you, an explanation on nadir and what the nadir is when somebody is taking chemotherapy. Now, nadir just means the lowest point on a curve. Okay? There's nothing magical about a nadir. Sorry, I'm going to make this a little bit smaller. Okay. So let's start with drawing our nadir over here, drawing our graph. And not really a math graphy person, but this will work just fine. All right, so why is this important in chemotherapy? Well, the nadir is the point at which the patient is the most susceptible to infection. We already know that cancer patients are susceptible to infection. And part of the reason they're susceptible is because the chemotherapy kills rapidly dividing cells, right? Kills stem cells. And the stem cells, remember, stem cells make WBCs, red blood cells, and platelets, okay? So part of the WBC that we're interested in is the ANC, and that's a parentheses over here, sorry. All right, so I'm going to talk to you about what this looks like here, and I'm actually going to erase some of this so that we have some room to actually see what's going on. So, whoops, eraser, 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 there, eraser, 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 eraser. Okay, but what I just erased is important, so don't forget that. Okay, so let's just say here that we have this graph, and I'm going to go back to my original color, and let's just say that right here, this is, whoa, that's not going to work. This should be entertaining just watching me try to do notability, which, you know what, I have no shame, so it doesn't matter. Okay, so let's just say that patient has a normal white blood cell count or a normal ANC. Let's do ANC. This will be ANC, right? And this will be days down here. Whoops, day. It's not happy with that either. It'll be days. Days. Okay. Now, what do we mean about days? This is days since chemo given. All right. So let's say right here, day 0, chemo is delivered. Okay. Chemo delivered to patient. Should say administered, but that's okay. And then we go, let's say for, this is 0. Let's say this is 1, 2, 3, 4, 5, 6, 7. So let's say this is day 7, 8, 9, 10, 11, 12, 13, 14. We'll do 14 here. 15, 16, 17, 18, 19, 20, 21. Okay, so here's 21. Okay, so this is days since chemo, right? Since chemo. Now, up here, this is our ANC. So let's say the patient starts out with an ANC. Now, remember, ANC measures its absolute neutrophil count. Okay? Different than a white count. All right? So it's a part of the white count, but it's the remember, you have white blood cells and you have all these different cells. You have lymphocytes, eosinophils, basophils, you have neutrophils is one of those. We're interested only in the neutrophils for the most part, okay? So we're interested in neutrophils, and let's just say that the patient starts out with an absolute neutrophil count of 3,000, all right? Which means about a third of the way down here, we could say 2,000. This isn't exactly to scale, but you get my drift. and this is about 1,000, and let's say down here we have 500, right? ANC of 500, and then down here we can actually get to 0, okay? All right, so I'm going to go change my pen color so I can draw you a different curve. All right, let's say the patient gets chemo, day 0, and we are doing blood counts every day. So let's say they start right here. Now let's say on day 1, their ANC's down a little bit. Day 2, it drops a little more. Day 3, it's getting less. Day 4, maybe we're here. Day 5 or 6, whatever this is now, it's dropping. Day 7, we're at 500. Maybe by day 8 or 9, we're getting even lower. By day 11 or so, we're almost to 0, and then at some point we actually hit 0. Now, if I were to draw a line, right, this is the curve that I'm talking about. Now, if we keep taking the patient's CBC, right, we're going to start to see it go up. Now, it probably won't go up quite this precipitously, but, for the sake of this discussion, this works just fine. All right, and it starts to go up, and eventually, it'll get up to a point where it's kind of back to normal. So it's down. It'd probably be more of a bell shape than this V shape, but this point right here is the nadir. Okay? One of the things that you learn when you're giving chemotherapy is the nadirs of the drugs that you're giving. So we know from giving these drugs over and over to patients that, for this particular chemotherapy X, the nadir is around day 14. All right? Which means your patient at this point has almost 0 neutrophils. So what does that do to their infection fighting ability? It basically makes it zip, okay? No ability to fight infection, okay? So they're down here, all of a sudden they show up at the clinic, or they make a phone call and they're like, hey, guess what? I have a fever. And the temperature, for it to be a fever, has to be greater than 101 Fahrenheit or equal to or greater than 38 Celsius. Okay? It's not a temperature until then. It's not a fever. But this right here, the temperature combined with this, no bueno. Bad news for the patient. Because now we have some evidence in the form of a fever that our patient may have an infection brewing, right? So, what do we do? What's the first thing you want to do? I know the first thing you want to do because I've been teaching nursing students for a very long time. And the first thing you want to do is you want to give them something for their fever. Okay, so great. Let's give them some Tylenol. Because remember, these guys can have no NSAIDs, so they can't have ibuprofen, right? So you want to give them Tylenol. Well, great. Now their fever's gone down. But does that change the fact that they're at risk for an infection? No. All it's done is make the fever go down. But meanwhile, whatever's brewing, right, in their body because of this is still having a little party. So, the nurse's number one responsibility, by the way, this is called febrile neutropenia. And in nursing language, it equals 911 emergency, okay? It is considered a medical emergency. That's how important it is for us to do the right thing and to recognize when we have a patient in febrile neutropenia. Why am I going through all of this for a pharmacology course? Because when you give chemo and you give medications, you have to take care of the things that occur as a result of delivering those medications. Okay, so Tylenol is fine, but that's not your first priority. Your first priority is to help identify whatever it is that's causing this infection. So number one thing we're going to do, that's a one, is cultures, right? And it might be blood. For sure it'll be blood. Urine. Okay. Whatever else we're worried about. So blood, urine, could be sputum, whatever. But always blood. This is the primary one that we're most interested in. Because these patients with such a low nadir are at risk for a very significant infection and basically for becoming septic. So we do cultures. Number two, we will give broad spectrum antibiotics. You're going to learn this when we talk about antibiotics, but broad spectrum, it's like the machine gun, just kind of kills a whole bunch of different kinds of bacteria. And that's fine for the initial dose. But ultimately, we want the results of our culture, right? Which is going to take 3 to 5 days. And we want to know the actual bug, right? We want to find out what it is. And then we'll change our antibiotics over to something that's more narrow spectrum and designed for that particular bug. And then here, number 3, now we give Tylenol. Now, in reality, am I bringing Tylenol when I go get the stuff to draw my blood culture? Of course I am. But the true priority is this. It's the culture. If you swap these two and you're like anxious and you're like, oh my God, I'm going to get antibiotics on board. If you give these first, antibiotics, and you switch these around, you're going to give antibiotics, they're going to start working right away. And if you add something growing in the blood, you may not catch it now with your culture. Your culture may come back negative. Even though your patient's on antibiotics, we may now not know what bug is making them really sick, like life and death sick. And so culture first. Always, always, always culture first. And that is something that I guarantee you will see on an exam. So let's just put this into actual use and say patient calls, chemo 1 week ago, chemo, let's say 2 weeks ago, and now they have a fever. What are we going to do? We need them to come in pronto. And as long as they're just febrile, they're not dizzy or have decreased level of consciousness or anything else like that, they can actually come in to the ED or to the clinic. And here we go. We're going to start this process right here. This has to start within 30 minutes of admission or of discovery. Okay? This is very common, this 30 minutes, this is very common, and you'll see it in the ED. You'll see it on hem-onc units. And most nurses have what we call standing orders. So you will have febrile neutropenia standing orders. And if you read those orders, it will say things like draw a blood culture, from either if the patient has a central line, you'll want to draw it from any lumen that they have. If they have a double lumen, you want to draw a culture from each lumen and you will want to label it. If they don't have a central line, then you will draw it from a peripheral stick. Urine, they may ask for a chest x-ray. They may, and then they'll ask for usually fluids to be given, and then starting a broad spectrum antibiotic. The one that is used a lot at Rady's is cefepime, and it is good for gram-negative bacteria. Okay, so we'll do cefepime. So cultures, then antibiotics, then Tylenol. Then, number 4, call the doc and let them know that you did all this. That's the last thing you're going to do is call the doc, okay? Because we're going to have these febrile neutropenia standing orders, which means the nurse can initiate these. She can begin them. The doctor has to write them and have them in the patient's record, but the nurse can initiate it because we don't need them until the patient's here, right? Until the patient's febrile. All right, guys, I hope that explains Nadir and why Nadir is so important. Why A and C is so important in relationship to giving chemotherapy. And if you have any questions, then we'll go over this when we do our case study on Friday. All right.